Jessica. We're
Hi,
here
Stacey.
for Overdose Awareness Day, which is always sort of a solemn and kind of overwhelming day to think about, especially in 2026. But it also is an opportunity for us to think and talk about ways we can help keep the progress that we've made so far going. And that's part of why I'm super excited to talk to you today about some of the conversations that you've had recently and what we can all take away from that. Um, so I'm Stacey McKenna. I'm a senior fellow and associate director in healthier communities at the R Street Institute. And I'm here today with my amazing colleague, Jessica Shortall, who I will let introduce herself.
Thanks. I'm Jessica Shortall. I'm the strategic partnerships lead for our Healthier Communities team. So it's a lot of coalition building and talking to folks with lived experience and organizations and people doing the work of healthier communities, including harm reduction and addressing substance use in our American communities.
Which is how we get to today. Um, so one of the things that we talk about all the time, Jessica, is that we have all these statistics, right? Like we know that even though we've made some incredible progress in recent years fighting the overdose crisis, more than 10,000, tens of thousands of Americans are still dying every year of an overdose, mostly opioids. We know now that more than 40% of Americans have lost someone in their life because of an overdose, and something like 3 in 10 say that either they or a family member has struggled with an opioid use disorder. Which we'll sometimes refer to just as addiction because it can be less of a mouthful. But it can be really hard to get your head around those numbers, right? Like what's 40%?
Yeah.
What does it mean for a family member to be affected by or know someone who struggled with an opioid use disorder? And I know you recently talked to a couple of moms whose children had been struggling with opioid use disorder, and wrote about it with our colleague Chelsea. And I would love to talk to you today about the article that came out of that.
Yeah. Yeah, I'd be happy to. It was probably the hardest thing I've ever written in my time at R Street because it was so personal. And I was super grateful to these two moms for being willing to share a little bit about their family stories.
Can you start by just telling us a little bit about who who these kids were and who their moms
Yeah.
are?
Yeah. So the moms I talked to are friends at an organization called Broken No More, introduced me to them, Sarah and Kathleen. Um, and I just spent kind of a lot of time talking to them on and off on the phone, on Zoom, on email, just learning about their families and their the ways that their families have been specifically impacted by opioid use. So Sarah, and I'm a mom, and so I have a teenager, two teenagers now. And so it was like very, very personal for me. And it was, to me, I think like those big numbers that you mentioned can be really overwhelming. Sometimes I think for some people they can even be kind of numbing because it's like, well, that's so big. What am I supposed to do about that? So I find it really helpful to talk about and have the opportunity to share what does this look like when you zoom down to one or two? And everyone's experience is going to be different, but I was really stunned at the many similarities between these two family stories. So Sarah told us about her son Aiden, um, who passed before his 18th birthday a few years ago. And first, I'll say, like, as a mom, so important to me. I said to both of them, "Tell me about your kid." So he sounds amazing, creative, very fast moving, like very energetic, reminds me in her description a lot of my son. Loved his siblings, super competitive, very much my son. Um, so Sarah told us about Aiden, and then Kathleen told us about her daughter, Molly. And again, like bright, loving, compassionate, stubborn, and she used the term genuine LOL funny. And I just really I always like hearing about people's kids. So these are beloved and really fantastic people. And I think we do get reminded in different ways that addiction can impact anyone. Um, and that I just think to me, it's a reminder that everyone impacted by addiction is somebody special and important and loved. And deserves to be known not just as their addiction, but about all of the cool and interesting things about them. So that was a really great part about talking to these moms.
Yeah, and I think I mean, that's something that sometimes gets lost in the conversation, right? And the desire to sort of fixate on the tragedy as a vehicle to preventing more tragedies.
Mhm.
We end up losing sight of the bigger picture, the bigger human. And I mean, honestly, in there, we might have clues for how we could do a better job as a society in helping these families and these individuals and ultimately the communities that they live in.
Right,
Um,
right.
so I think one of the things, like the main takeaway from this piece, right, was that getting medications for opioid use disorder, which there are two main FDA approved ones called, well, there's three FDA approved, but there are two that are the most effective and most frequently used, which is methadone and buprenorphine. And so you'll hear those come up a lot during this conversation, but they are medications that are proven to reduce illicit drug use. They reduce cravings and withdrawals. They can really make a huge difference in helping folks get to a point where they have stable enough brain chemistry to really engage in recovery for them. For them, that might look like um, starting work again. It might be really intensive behavioral therapy. It might mean being able to engage in family responsibilities or celebrations or other things like that, right? So it's really about coming back to being part of life um, in a fuller, richer way. And they're the most effective tool we have. And yet, on fewer than studies kind of range from under 20% to about 25% of people with an opioid use disorder actually access these medications. And your piece and your conversations really highlighted that not only is it hard for people to access these meds, it's often a lot harder than it is to access the illicit substances.
Right, right. And that was not a theme that I went in looking for in these conversations, but it just jumped out.
Yeah.
That both of these moms, so like I said, like Sarah, lost her son Aiden a few years ago. Um, Kathleen's daughter Molly is doing really well, and that's great. But has had a long road, many, many years. And both of them use the word beg. They said that they begged providers, that their kids tried so many different rehabs and treatment options and what have you, and that they were begging for the opportunity to try one of these medications. And just like, what I've learned from you, especially, is like with any medical condition, different, there's some, when I have when I'm sick, there's some medicine that works well for me and doesn't work well for the person next to me and vice versa. So like the opportunity to try and figure out what works matters
Yeah.
too. But just to even get the, ability to try one of these medications, both of these families used the word beg. And that begging didn't go anywhere. And some of that is like a lot of rehab facilities have a abstinence policy that includes these medications that somehow like lumps them in with illicit opioids and other illicit drugs and says like you can't be taking anything, including these like FDA approved gold standard evidence-based medicines. So, trying all of these different rehab programs and facilities, inpatient, outpatient, whatever, and asking and then begging became a really big theme. And that just really struck me because both moms also described the ease with which their kids were able to continue to access illicit drugs because, the person or people selling to them don't have any of the regulatory barriers that this country has around methadone and buprenorphine. So that person that is going to sell will come to you, rain or shine, middle of the night, whatever. They will, transportation's not a barrier. Um, regulatory approval's not a barrier. So, um, continuing to stay in that addiction was just that was like a glide path compared to this like trying to claw your way out of it and not being able to get access to these medications that researchers describe as gold standard. Just yeah, that really jumped out as a theme for both families.
Yeah. Yeah. And those regulatory barriers. So buprenorphine and methadone operate very similarly, but not identically to each other. Buprenorphine is considered a bit safer because it only turns those opioid receptors in the brain on a little bit. And so even if you take really high doses of it, there's not much of an overdose risk. Whereas with
Hmm.
methadone, at high doses, there can be, even in folks that have tolerance. But when it's managed properly with your provider, it can be taken in a way that's quite safe. Um, but because of these differences, it also means for some folks, methadone works a lot better. Whereas for especially with fentanyl, because fentanyl is so potent that for some people, buprenorphine just isn't turning that receptor on enough to help alleviate the cravings or the withdrawals. And so they still really struggle. And methadone is a better option. But as you mentioned, right, there's all these regulatory barriers. And so, like with methadone, methadone is currently only available for opioid use disorder through opioid treatment programs or OTPs in the United States. And a lot of folks still have to go every day, 6 days a week, to the OTP to get that medication and often take it under supervision. Some states even require that when they do their urine screening, those are supervised. I mean, states have all kinds of extra barriers. The average transportation time to get to an OTP is around 40 minutes each way. This can be a huge deterrent for folks if they're trying to hold a job, if they're having to care for a child, right? A lot of people don't want to bring their kid to the clinic and stand in line with their child while they're waiting for that. They might not have a car. So all of a sudden, a 30-minute drive time becomes a how do I find a car service that'll take me there, right? It turns into a big barrier. Buprenorphine's easier to get. Any prescriber who can prescribe scheduled medications can prescribe it now, which is awesome. We love that. But we know that less than half of pharmacies dispense it and stock it, right? So there are still lots of barriers to getting that medication. And as you mentioned, right, like there are hours on these clinics. There are often narrow windows that you can go for dosing for methadone. If you are purchasing on the illicit market, that's not really there.
Yeah, a couple things here jump out. I mean, one of them is that so one of the, kids, now adult kid in this piece had an hour commute each way to the nearest OTP. And she was doing it. She was putting in that work, and then she was able to get take homes, so not have to go every day and be able to bring some doses home. And that was helpful and it was working. But I mean, I think the thing about take homes is that we need to remember is that they are precarious because the OTP, the methadone clinic, can revoke them for any number of reasons, many different reasons. A missed phone call to come back to the clinic, which is what happened in this case. A urine screen that has tested positive for THC, for cannabis, rather than for opiates or for opioids. Lots of things. So when that happened in the piece that we wrote, um, that then became that daily commute back and forth to the OTP, and that didn't feel safe because there were people kind of near there that were using drugs and selling drugs, and and being committed to recovery, that's hard to be around for some people. So yeah, it's a precarious situation. So in that story, in the piece we talk about that she switched from methadone to buprenorphine because of that having lost access to take homes and having to go back to the clinic every day. Um, and it worked for a while until a family tragedy struck. And that's destabilizing for any of us, right? Like, any of us, I think, can really spiral when we're experiencing significant grief. And she just found that the buprenorphine didn't hold her in the same way that methadone did, because again, different medications work well for different people at different times in their lives. And so then that experience triggered a return to chaotic drug use and a whole bunch of really awful period, in life. So I mean, that's all that kind of story is all wrapped up in many things that you've said here about the difference between the medications, and some work for some and some work for others, but also the difficulty of accessing methadone persists because the United States has placed methadone in one channel only. And that basically makes that clinic a little monopoly. There's no, especially for people in rural areas where maybe they can only get to there's only one clinic within even an hour of driving distance. There's no one for that clinic to compete against for that person's attendance, for that person's business, if you will. And so that doesn't provide any incentives for the clinic to have better opening hours, longer opening hours, to make those take homes less precarious, to treat patients with more dignity and empathy. It just, some of those clinics do that because they're run by good people who understand that that is the right and evidence-based way to do things, but some don't. And so then we have this system where people are forced into this one kind of monopolistic clinic, and then they get what they get. And like you said, the person that will sell illicit opioids to them isn't going to do any of that. They're going
Yeah.
to meet them right where they are and sell the product.
Yeah. And I think it's really worth like side noting here the intensity of withdrawals for people, right?
Mm,
So when folks are physically dependent on opioids, even if they don't have a substance use disorder, right? This is something that really stands out is how many of us have probably experienced some physical dependence on opioids. Like I remember my dad having neck surgery or shoulder surgery, and he was like 3 or 4 days in, he was like, I started to notice
mm.
that I was developing a physical dependence. He didn't have an opioid use disorder, right? They're
And
two separate things. So, but the
what that meant
physical
was he felt
dependence,
crappy.
it meant he started to feel crappy if he was starting to get late on taking his next dose. And when you're talking about someone who's physically dependent on especially fentanyl, or methadone or buprenorphine, right? So even if they're in recovery, they might still be physically dependent
Mm,
on the medications, but they're not like having the compulsive feelings and behaviors that come with having an active addiction, right? But that physical dependence can really, really be a challenge. And it's associated with things like a lot of the time it's called a flu-like symptom, like cluster of symptoms. But if you talk to folks, that's really underestimating how bad it
mhm,
can be. It can be associated with just like massive like sweating, chills, body aches, fever, vomiting, diarrhea. It can be like startling, scary in the wrong place
oof.
diarrhea, right? Like these things avoid the desire to avoid feeling this way is really strong. And if it's then also tied to I haven't yet learned other coping mechanisms
Mm.
for the emotional and other factors going on in my life. It gets complicated. And then you can't get your medication. You're now physically in withdrawal, actively struggling with exercising new coping mechanisms. Maybe you haven't really built them up yet. And what's your option?
I think this is something I did not understand until I started working at R Street about withdrawals. That like I think I definitely, maybe the average American, I definitely had the sense like, yeah, that sounds like it sucks for a day or two. I just didn't know.
Yeah, of
And then
course.
to learn, no, this is like you don't some people say like I felt like I was going to die.
Yeah.
It is beyond anything that any movie has shown us, any popular culture, any kind of description of like, well, too bad. You feel crappy for a couple days and then you're through it. And that's not how it works, is what I've come to understand. And I think also the kind of popular perception of opioid use is that people with opioid addiction are taking opioids to, in the kind of general parlance, to get high. And that is not the case once you are pretty far down this road. You are literally just trying to stay well, trying to not have this full body pain, incapable of going anywhere, like you said, because of diarrhea and vomiting, sweats, all kinds of horrible symptoms that consume you and could, there's nothing else that you can do except experience this withdrawal. That at that point, using opioids is just to get back to a functional baseline.
Yeah, a
And I
hundred
think I
percent.
think a lot of us don't know that.
Yeah, and it's such a big piece of it. Um, and I think that feeds into some of what we really love about the medications too, right? Compared to illicit opioids, because fentanyl is sort of notoriously short-lived. Um, the people have been reported injecting, like I've seen studies of like average of like something like 10 times a day to avoid withdrawals. You see a range though from like 3 times a day to 18 or so times a day. Every one of those injection points, right? Like every time a person is injecting illicit fentanyl, they are increasing their risk for transmitting infectious diseases like HIV or hepatitis C. They are increasing their risk for overdose. They are increasing their risk for skin wounds, right? And like the
Hmm.
infections that come at your injection site. All kinds of factors are a risk. And it's not, as you said, in the quest for a high, it's to avoid being ill.
Hmm.
Now, with buprenorphine and methadone, both of them they both have really long half-lives. They both can keep you sort of stable, right? For a good 24-hour period. They can go a bit longer, but if you really want to make sure you avoid the withdrawals, daily dosing is ideal. Buprenorphine has a couple of long-acting products available, like a couple of long-acting injectables that for some people can be a really good option. Not everyone. It just depends on the person, and we really like when the government kind of lets that decision be between the patient and provider instead of trying to dictate those through policy. But so part of why methadone and buprenorphine work so well for this stability is that they last a long time, right? And so you take them once a day, you don't have this constant cycle all day of not just like risking withdrawal, but then trying to score to avoid
Hmm.
withdrawal, right? So there's a lot that goes into all of that. But buprenorphine and methadone also, so fentanyl, when you take fentanyl at first, even if you're tolerant, you might not be getting high, but there's still like, it acts really, really fast, like really fast. That's part of why it's so dangerous for overdose because the onset is like 30 seconds to a minute. It's super fast. And so it comes on and it goes like that, right? And then a few hours later, you're crashing and you're way below your baseline and what was normal. With both buprenorphine and methadone, the onset is slow. It's like a half hour to 2 hours, maybe peaking a couple hours out. So it comes on really slowly and then it levels, right? And then you titrate, you find the right dose with your doctor that works best for you, and you're able to maintain this stability, right? So if you picture it, you have fentanyl that's having people going up and down and up and down. Buprenorphine and methadone, let them stay level, which makes a
Right.
big difference in terms of reducing overdose risk, in terms of reducing injection likelihood. And I think something people forget to talk about is in terms of your ability to go about living your life. Like
Uh-huh.
imagine trying to hold a job if every couple of hours you just got really ill and were worried you were going to vomit on your desk or you couldn't focus because you were shivering and sweaty.
Right. And I
Like,
think we have this narrative of recovery, addiction and recovery of like, you've got to get on a good track, you've got to get a job, you've got to have purpose, etc. We're making it harder for people to do that
Hmm.
by making access, our regulatory and policy landscape makes access to these medications too difficult for too difficult for many people to be able to jump through.
I want because this is Overdose Awareness Day. Um, I do want to take it back a little bit to specifically overdose. And we've talked a little bit about why these medications can help reduce overdose. And we've talked a little bit about why fentanyl increases that risk so much. But I'm going to give you another statistic, right? And it's that medications for opioid use disorder decrease overdose risk by as much as 80% compared to non-medication treatment. And there's actually some research that's come out recently that showed that non-medication treatment can increase that overdose risk, that can make it more dangerous than continuing to use. Um, so kind of as we take our last few minutes, I wonder, Jessica, if you'd talk a little bit about what you learned about how that like inability to access medications for opioid use disorder impacted Aiden and Molly and
Yeah.
put their lives in danger.
Yeah, right. I mean, like the big picture from that data, which is just stunning. We hear so much, so many headlines about reducing the supply of illicit drugs into and inside this country. But I mean, everyone in the world, you say supply and everyone automatically thinks, well, demand. These medications can reduce that demand on the individual level, so for an individual person, and on the population level to help fewer people seek out and use illicit drugs, which I feel like is and should be the shared goal, especially today on Opioid Overdose Awareness Day. Um, so, yeah, I mean, I just having heard from these moms about how hard their kids worked. And I think that too kind of busts another stereotype a lot of people have about people who use drugs. It is hard work, as you point, the work to feel well, stay well, try to be productive, participate in your family life, the work to score, to, find additional drugs to keep those withdrawals at bay is all of that's hard work. And on top of that, someone that is seeking recovery, that is very hard work in a lot of different ways. Um, and both of these moms talked about that, about how hard their kids worked. And that's fine. It's good to work hard at things, but we are unnecessarily making it much, much harder. So, like one of the moms said, Sarah said, her son spent a year and a half trying to dig himself out of the darkness. And a lot of it, these pieces that we write are 800, 900 words. We had long conversations where I was amazed at this kid's tenacity and his hard work and how much he wanted to be able to move on from this addiction. He worked really hard at it. But the one thing he kept, like I said, and his mom begging for, they could not get. So you're trying so hard to stay alive, to not experience an overdose yourself, to get back to the life that you knew before all of this and go after the dreams you have for yourself. And that trying is just hits this brick wall of not being able to access a medication that I think you should have the right to try and see if that works for you. And so we saw that with, stories from both of the moms that just the incredibly hard, persistent work that their kids did. But this was kind of among many, but it was the brick wall that their kids ran into was being able to access and then stay on this medication consistently. And it wasn't for lack of trying. It was our system. And that's where, to me, like data and policy and personal stories all collapse together to make a really strong point, is that that's what happened in both of these cases. And as a result, one mom lost her child and the other, thank God, her daughter's doing really well, but 20 years of ups and downs. And like I said, not through these two individuals and their moms and their broader families, not through lack of effort, just through lack of access, which to me, like we could change that. We have the ability to change that. And we would see less overdose and more, stable and productive lives and fewer of these interviews and stories to tell, which I think would be a success.
Yeah.
If you want to read more about these stories, you can do so at the link.
Yeah, so if you want to read some of our policy work on medications for opioid use disorder, work on how they work, or why they're difficult to access, you can find them here.